Welcome to the JRCALC podcast. Join us as we delve into the latest updates and insights from the JRCALC guidelines, your essential resource for paramedic practice. Whether you're on the front lines of emergency care or simply passionate about pre-hospital medicine, this podcast is your go-to for staying informed and up to date. Each episode will break down the newest guidelines, discuss their implications, and hear from experts in the field. So, wherever you may be listening from, whether it be on the road or at home, settle in and let's better understand the world of paramedicine.
Thank you for joining us to talk about the new paediatric end-of-life care guidance in JRCALC. My name's Georgina Murphy-Jones. I'm currently Deputy Director of Clinical Pathways for the London Ambulance Service, but I'm here due to my previous role in our Macmillan end-of-life care team. During my work in this improvement programme, I wrote this new paediatric end-of-life care guidance, which has now been adopted nationally. This guidance was written because at the start of our programme, we identified that there was nothing available to support ambulance clinician decision-making and actions on scene in terms of this specific patient group. And so I worked closely with colleagues in specialist palliative care teams and reviewed cases that we'd attended to write this guidance. As part of my work, I've been collaborating with another Georgina who I'd like to now introduce.
Thanks. Hi, I'm Georgina Brightley. I'm a clinical nurse specialist in the paediatric palliative care team at Great Ormond Street Hospital.
I suppose a good place to start is, could you define this patient group that we're talking about?
So I guess the first thing to highlight is that paediatric palliative care is quite different to adult palliative care, which is more associated with the end stage of life. When we talk about paediatrics, we're talking about infants, children and adolescents, or children and young people up to their age of 18. And in general, paediatric palliative care happens from the point of recognition of a condition that may be life-limiting or life-threatening. In general, we use the Together for Short Lives categories, and today we're going to focus mainly on children with life-limiting conditions or life-threatening conditions.
That's really helpful, thank you. But I think what's so difficult for us is the range of conditions. So I'm sure you're not an expert in all of them, but we absolutely aren't. And a lot of the time we won't have even heard of these conditions. And so that can be really difficult for us walking into a situation, managing a condition we've never even heard of. So I think what's really important for us as ambulance clinicians is acknowledging that and being honest with the parents. I've never heard of the condition. Have you got any information, a care plan, or can you tell me about it? Because it's not something we can clearly bluff our way through. And actually what we need to do is access the specialists in your case, your teams. So I think it's just worth acknowledging the range of conditions, over 400 in this patient group.
Yeah, exactly. And as you say, some of them might be very, very rare and only a couple of children in the UK or in the world with them, where there might be other conditions that are slightly more common, particularly things like your childhood cancers, where they might be more common in the paediatric world, but not necessarily in the ambulance world. Shall we go through, George, the guidance from thinking about when a paramedic walks into the front door after a 999 call has gone out, and think about how the guidance should be used or could be used from there?
Yeah, I think that's a really great idea. And we'll pull out some of the key points. And I suppose for me, walking into scene, we do that immediate assessment. But for me, there's that recognition that this is an end-of-life care situation. I think that's probably one of the biggest messages we have is to look if you have any suspicion or to ask for a care plan. Early on is probably the biggest thing. But what would you say about recognizing if this is an end-of-life care situation?
I think from our initial discussions before the guidelines was made, the important thing that we said was to just have a pause, stop, look around you, look at the environment. Is there equipment in the house or are there signs in the house that this might be an expected end-of-life situation or palliative situation? So you could be looking at things like what equipment's around. Is there a hospital bed in the house? Do there seem to be lots of medications? Are these parents au fait with what's happening with their child? Are they talking in a way that makes sense to you, that they know what might be about to happen here?
And I think it's difficult for us because we do see medical equipment. It should be a bit of a red flag. This is abnormal. But when we think about feeding tubes, non-invasive ventilation, even home oxygen, it doesn't necessarily mean the patient's at their end of life. And actually, coming back to your earlier point, they may not be at their end of life. They may just be having palliative care as part of their normal treatment. But what's important is we recognise that so that we can manage that situation appropriately. And it may not be hospital attendance. So it's about, I suppose, being inquisitive, picking up those signs. It may be that a child has a physical abnormality. And so when you first look at the child, something makes you pause, as you said, and maybe question, but it's a sensitive conversation with family about their medical history. Have they got any specialist teams? And they may not. From our learning, we know that parents may not know the word palliative care team. So we have had cases where the crew have asked that and the parents said, no, because they didn't understand it was a palliative care team. So it's maybe thinking about the wording and how we have those sensitive conversations.
Yeah, I absolutely agree. And it may be that a child has a condition that is life-limiting in its nature, but we're not at that point yet, and you don't have a specialist team or you haven't had that conversation yet. I think one of the important things that we've learned is to think about, as you've said, the wording. So try to come up with different phrases that people might go by. So sometimes for palliative care, we would say symptom management, for example. And the same would go for thinking about advanced care plans, or we would call them in my team a respect document. But geographically and locally, if you can try to find out what those care plans where there is a documentation of conversations about things like resuscitation status, wants and wishes for your child if they become more unwell or in the end of life, then that's really important, because that's what that family are likely to know their documentation by. If you use the right phrase, you might get the right piece of paper that you're looking for. And also thinking about things like in London, we use the Universal Care Plan, but you might have some documentation that flags on your own ambulance system that there is a care plan in place. So if you can remember to try and check that, that's also very beneficial.
And thinking about care plans, it's this population being paediatrics is sometimes different to adults, where we come across adults who don't have a care plan. But most commonly, what's reassuring for us is these patients are known to specialist palliative care team. They're most likely to have a care plan. So that's reassuring for us. And I suppose for a rough guidance for our clinicians, we talk about it in the guidance that it's so important to ask the care plan, because it will either have specific directions of what you should do, symptoms that are expected, but actually where that's not included, the advice for our clinicians is to always opt for full active management. So it's really getting the care plan, because that will tell you what to do alongside the numbers of the specialist team. But I just wonder if we should touch on, it's quite a unique situation, the parents' role here, because and it differs to adults. We're always saying follow the care plan. But in this situation, we may be faced, and then we'll come on to it later, with situations where we may not follow the care plan on the parent's request. And actually, the parents have quite a key role, don't they, in these situations and decisions.
That's exactly right. So I think it's important to recognise that in the paediatric population, any of the documentation around advanced care planning is not legally binding, and we will have had a conversation with the parents about that. So you may arrive and documentation says that a child is not for cardiopulmonary resuscitation, or they're for some kind of modified resuscitation, which I think you also don't get quite so much in the adult world, but they may be for things like oxygen suction and airway positioning, but not for cardiac compressions. But ultimately, if you have a family that are asking you to do everything, then we would say you absolutely should go with what they're saying at that time. I think this is also a good point to also mention, Georgina, just about, do bear in mind safeguarding issues. And if you attend a family home and you've got any worries about anything to do with safeguarding, don't just dismiss this because this is an expected death, because we know that these children are and young people can be incredibly vulnerable. So if you've got concerns, please do escalate them.
That's an important point. And thinking about the parental role, we often lean on the parents for support because, as I said, it's a condition we don't know. But actually, it's not just leaning on them because they're the experts and have the knowledge. They know that child well. So what we really want to identify as a child we've never met or young person, what is their normal baseline? And actually, the parents will tell us that. But it's being aware that whilst they're the specialist and we should always be looking to them, they are still parents. So they're playing this dual role, aren't they, of needing our support and guidance. And often they know what to do, but actually it's reached a crisis. Something has happened that's unexpected, and what they want is our support and guidance. And so they're switching between these roles, and I guess that's something for us to manage too.
Yeah, definitely. And I think you've highlighted a great point there, that often these children will have a very different baseline or different presentation to what you may expect from adults that are at their end of life, or from sort of a normal, healthy child. So it wouldn't be unusual, for example, for me to be caring for a child with a cardiac condition where their baseline sats are in their 50s or 60s and they're incredibly cyanosed. And I can imagine as a paramedic walking into that would really make you panic. Whereas for me, I might think, well, that's their baseline. So it is important to check out with parents, what made you call today? What is it that you're worried about today? And what's normal for your child, because that can be very different throughout. And that can also help guide then with what you're actually looking and assessing for, and what do you need to treat. So if someone's baseline saturations are 55, you're not going to have to give oxygen if that's the situation, for example.
And I think you've really highlighted there how different a situation is and how worrying. We're so used to taking a set of observations at this point of assessment, and they're going to possibly be very deranged, and the child's going to look very unwell, and that's going to make us feel very unsettled. We're really out of our comfort zone now. So I think it highlights the importance of contacting the specialist care team to know what is normal. So going with what the parents say, but also we are usually there when a symptom has worsened or something has happened, because we know the end of life can be unpredictable and deterioration varies. So we need to try and work out, could this patient be dying? Is this a normal episode? And actually, we need that information to put that into context. And it's beyond our scope, knowledge, and abilities to do that. So it's that conversation, calling their care team, the healthcare professionals that know them, to say, this is what I'm looking at. Have you seen this before? If it's what you'd expect, because you'll have that context and knowledge of previous episodes. And I think that's why one of our biggest messages is to call the specialist team who know that child. So thinking more about symptom control, we know that in the new JRCALC guidance, there's a list of common symptoms that we may be presented with, that the child and person may be experiencing. How will the advanced care plan also support us?
So lots of patients will have a bespoke plan, either a separate symptom management plan or as part of their advanced care plan, that outlines what kind of symptoms we might anticipate that they have. So that will be dependent on their condition, but we'll just help you work out whether this is in sort of the realm of possibility of what we expect you to see when you walk into the house. And then there will be an outline of how to manage each of those symptoms with both non-pharmacological interventions, such as keeping a calm environment, as well as pharmacological management strategies.
And that's so important. And we've made sure to highlight the non-pharmacological things that should always be first line in the guidance. I think also it's worth touching on the pharmacological for us, because in terms of administrating our trust issued morphine, there is a difference with pediatrics and adults that's in the JRCALC guidance. So morphine can be used for pain, managing pain in adults and pediatrics. But in terms of our trust morphine, that's not to be used for breathlessness within pediatrics. That's only for adults. And really, we want to turn towards using what has been prescribed as anticipatory medication or just in case medications, but it's very dependent on your local guidance in terms of your trust as to what you could administer as a paramedic. But the preference is always that the parents should be administrating anticipatory medications Why is that, Georgina?
I think because lots of the medications are used off license or off label, but also because we don't often have medication administration records or MAR charts for children in the family home. So letting the family do that, they'll also know what has been given in the few hours preceding this and what is the most useful for their child. And they will have been taught how to administer everything that's on their chart.
And I think if we've reached the point of thinking about we've done assessment and symptom control, we're at the point we've got to make a decision about conveyance or not. And this, again, it's coming back to the parents. This is a shared decision with the parents, with the young person, if they're of an age to contribute to that decision, with the specialist team. And actually, we should probably always point out internal trust support mechanisms for you to get clinical advice. But actually, we want to really be focusing on contacting the healthcare professionals that know the patient and having that decision about conveyance. And it may be that the plan is to keep the child or young person at home and care for them at home. But actually, on this occasion, conveyance is the right thing. And so it comes back to there may be a plan, but we need to assess based on the current situation when we think about conveyance. And it's okay for parents and children to change their mind.
Yeah, definitely. As you say, it's all about the assessment. Speak to the people that know that child or young person the best from their healthcare professional team, because we also have to think about the background of what's going on at the moment. I think if it is decided by everyone involved that keeping the child at home is the right decision and there is a advanced care plan in place that is going to be followed that's not for resuscitation, it's then thinking about what we do around that time.
Yeah, and I think it's recognizing the signs that a child or young person could be dying. Would you be able to describe a couple of those common signs? I mean, obviously it could vary. We said that the end of life can be unpredictable. It could be sudden with no warning, where there's a lot of panic, or actually it might be a more predictable pattern deterioration where the parents have recognized that.
Yeah, definitely. It's very difficult to go through an exact process of what may happen, because it will vary depending on the child's diagnosis. But there are signs that we could think about, such as they've gone off eating and drinking or tolerated less food over food and drink, over the last few days or weeks. They might have been getting more and more sleepy, spending more time asleep than awake, or being what parents might describe as more difficult to wake up. And I think that's one of the very difficult things, as I'm sure you're all used to, is that often families will say they're asleep when actually we know that they've got an altered level of consciousness, but it's just not recognized in that way. Change of breathing pattern is probably the biggest thing that I would say we see. So breathing getting slower, longer gaps between each breath, and then their peripheral perfusion changing. But it is really important to remember that it can be different depending on the diagnosis, and that often, because in general, children have healthier organs than adults have, so they might look more well than you would think an adult at the same stage of life might look.
And I think whilst we've talked about symptom control, we need to think about, at this point, the families and the person's sort of faith or culture and what might need to be managed differently here. And I think for us, probably at this point, we've put in the guidance. You don't need in-depth knowledge. It's down to that individual family, but we can always ask what's important to you right now, and then ask what can we do to support you.
I think we found this in the past within my team a really helpful pointer to indicate to families that we think their child is about to die, by talking to them about cultural or religious things that you do around death. So, for example, in Islam, you would talk about moving the bed to face Mecca, and that in itself can be an indicator that we think that your child's coming to their end of life without actually having to use those words. But it is important to remember that not everybody will want to follow their cultural beliefs. And so you should ask that person or their family members what they would like to do, and not just presume that everybody will feel the same because of their background.
Yeah, such an important point to make. Just before we we finish, I really want to pull out one of the main situations that we found just from the cases we've discussed is the resuscitation decision, because often it can be at the point that the child has died where the parents panic. It may be expected, but they've panicked, and whilst they may be accepting that their child is going to die, they will retain hope, and of course that moment is unfathomable, and they reach out to 999 for support, and actually our clinicians are then faced with that decision. And I think from the cases we've discussed, the clinicians do the right thing. They instinctively know what to do, but it's to reassure that whilst there may be a plan that says not for resuscitation, it may be right to start resuscitation because the parents have requested it. And then during that time, have conversations with the family, and the specialist team will have had previous conversations about resuscitation and can support you at that time by speaking to the parents.
Yeah, definitely. I think it's just protect yourselves, look after yourselves, do what you feel is right in the moment whilst you're seeking and waiting for that senior support. And you will be supported by people around you afterwards if clinically you've done what you felt was best.
Absolutely. And there's guidance in JRCALC under verification of death. There's a flow chart there for expected death, which people can turn to for support in terms of what should we be doing right now. But I think you pick up on a really important point to end on, the psychological and emotional burden that can come with these calls, because they're very rare. We're unlikely to have had to experience them before. And I think it's really important that we take time as clinicians to debrief, to reflect by ourselves, or maybe share our thoughts, experiences, but also to be prepared that it's normal to have a range of emotions after such an event, and we utilize our normal coping strategies. But I think it's having that awareness in yourself, and really importantly in your colleagues, where more formal support may be required. And we know from talking to clinicians the value of having a conversation about what you saw and discussing, the emotions that came with it, how that helps people after these calls.
I agree. Definitely seek that support and debrief. Most professionals, I know we've done it a lot, are happy. The professionals that have been involved in the child's care are happy to have a debrief with you as well and go through what happened and how this was expected. But also just immediately after the call, take some time out, go and have a cup of tea and have some time together. Don't go straight to the next job.
So I think just to end, we'll summarise with the key points. There's really 3 for me. I'm pretty sure you would agree that we've said it all the way through, that parent participation is vital. We should always be seeking advice from a specialist team where available, and really essential is to ask if there is a care plan, because it will really provide us guidance on what we should be doing. So thank you for joining us. Coming in the new year will be a webinar looking at this guidance in a bit more detail and some case studies to help you apply it into practice. So please do join us then. Thank you, Georgina.
Thank you.
Thank you for tuning in to the JRCALC podcast. We hope you found today's discussion insightful and it will be helpful in your practice. Your feedback is invaluable to us, so please take a moment to rate and review today's conversation. You can contact us at jrcalc@aace.org.uk to share your thoughts and let us know what topics you'd like us to cover in future episodes. Feedback can also be submitted through the Parapass app. We'll catch you next time for more guideline insights. Thank you again for tuning in to the JRCALC podcast.